Good afternoon, everyone. Welcome to the webinar of the Geriatric ED Collaborative. We're happy to have everybody here. We already have a good number of participants, so you're welcome, and bring all your friends too. My name is Don Mulady. I'm an emergency doctor at Mount Sinai Hospital in Toronto, Canada, and I'm the host of today's webinar. We're continuing in our series of webinars about how to improve the care of older people in emergency departments around the world. When we were preparing this webinar, we noticed that we had done a similar webinar on accreditation in January of 2020. Remember those days? So it seems like that happened in a galaxy far, far away. So not only has COVID happened during that time, but there's actually been a huge development in the world of accreditation of geriatric emergency departments, and I'd say really on the whole concept of a geriatric emergency department. At that time, accreditation was a relatively new concept. Now, 20 months later, we have nearly 300 or over 300 emergency departments accredited as geriatric EDs around the world. So not only in the United States, but also Brazil, Canada, and Spain, with applications coming in steadily, including from East Asia and Australia. So last time we did the webinar, it was really sort of a nuts and bolts presentation about how to fill in your application form and things like that. Today, we want to extend the thinking about how you can use accreditation to improve your emergency department and the care that you provide to older people. So this will be valuable to anybody who's if you're coming from a hospital that's in the process or thinking about accreditation. But I think it will likely be valuable for anybody who's just interested in coming up with some new ideas about how you can improve care in your emergency department. We have a very diverse audience on, as usual. And just as we're getting started, could I ask you to type in where you're calling in from and what your role at that place is? And if you have any particular or specific questions about accreditation, please put them in there too. When you go to put something in the chat, just make sure that it is toggled to everyone, not to host and panelists. Next slide, please. The Geriatric Emergency Department, as you may know, is a network of hospitals and emergency departments around the United States and the world that are focused on improving care for older people. The GEDC educates ED clinicians about models of care to improve the care of older people. We support emergency departments and health systems with resources to implement those models of care, and we also research and evaluate the outcomes. So next slide, if you share our vision that your emergency department can be providing excellent care of older people and you want to join in the group, please join us. Membership is free. The link for the partnership is there, and Connor will put it into the chat. You can also follow us on Twitter at the GEDC and check out our website at any time. Next slide, please. The GEDC is generously supported by both the John A. Hartford Foundation and the West Health Institute. We really appreciate their support. We certainly could not do this work or do what we've been doing for the last 7 years without them. So today's webinar, as we've already said, is on accreditation of a geriatric emergency department. And once more, I just put that note there. If you have specific questions that you want to pose in general or to any one of our participants on the panel, please pop it in there now. Next slide, please. This is our panel for the day. Kevin Biese is an emergency physician at the University of North Carolina, and he's here today. Not only is he one of the principal investigators of the GEDC, but he's also the chair of the Geriatric ED Accreditation Board at the American College of Emergency Physicians. So he has led the charge in developing this program and participates with many others on it. Bridgette Dollhopf is a manager of nursing at Aurora Baycare Medical Center in Green Bay, Wisconsin. She works in a level 3 geriatric ED, and you will eventually get familiar with this vocabulary and what level 3 means. Her colleague, Aaron Malsch, is a clinical nurse specialist with the geriatric ED program throughout senior services at their whole healthcare system, Advocate Aurora in Wisconsin and Illinois. Luna Ragsdale is an emergency physician and the medical director of the geriatric ED at the Veterans Administration Hospital in Durham, North Carolina. Her site is a level 2 geriatric ED, and with her team, she led that accreditation. Nida Degesys is an emergency physician and the director of the age-friendly ED at UCSF, a recently accredited level 1 geri ED. And her colleague is Mitchell Erickson, an acute care nurse practitioner and a geriatric ED consultant in the same level 1 geriatric ED. So as we get started, I'm going to turn this over to Kevin Biese. Kevin, you're the lead of this program at ACEP. What do you think are tell us a little bit about the background to accreditation and what you think its value is for improving care.
Oh, thank you so much, Don. And I'm sitting here watching the chat and popping up all these folks coming from all over the world and coming from with lots of different backgrounds, physicians, nurses, quality managers, et cetera. And that's always really exciting to see everyone coming together. Please, everyone, lean in with your questions, put them in on chat. We'll do our best to answer them. So yeah, the accreditation story at the American College of Emergency Physicians only started in 2018, but the background of that starts way before that. A lot of us, including yourself, Don, have been working on geriatric emergency medicine for a number of years, but we're not the first. For decades, folks have recognized the disconnect between the way that emergency departments are structured, you get one chief complaint because I've got 20 patients and I can insert an algorithm to figure out what to do about chest pain or gunshot wound to foot or indigestion or whatever. You get one chief complaint and the needs of vulnerable older adults. That disconnect has been in existence for decades and written about for decades. Eula Wong, the other PI on Geriatric Emergency Department Collaborative, wrote about geriatric emergency departments in 2007. It was published in the Journal of American Geriatric Society. And JAGS, because emergency medicine literature wouldn't publish it at that time. It just didn't seem like a geriatric emergency department was a viable concept. But I think our story, really building on the shoulders of so many folks who became before us, started with the guidelines that were published in 2013 and supported by SAM, ACEP, AGS, and ENA, so the nursing and physician organizations within emergency medicine, as well as the American Geriatric Society, and then transformed into criteria for accreditation by the American College of Emergency Physicians. So the background is decades of research, education, literature, and committed nursing and physician clinicians trying to do a better job for older adults in the ED, which then got codified in a way in the guidelines and then the accreditation criteria in 2018.
So how do you think this is going to make a difference? How could an individual emergency department use accreditation to work on improving their care?
Yeah, no, great question. The concepts in accreditation aren't really new. It's not like if you're interested in accrediting, all of a sudden you care about older adults. Accreditation is a tool that ACEP developed for two reasons. And frankly, that I'm willing to dedicate a lot of my energy and career advancing for two reasons with colleagues like yourself, Don. One reason is for the public-facing part of it. Back in 2018, when we started accrediting EDs and saying, you get the stamp of being geriatric ED accredited, There was 100 or so EDs in the country out of the 5,000 in the United States that self-identified as geriatric emergency departments. And the contributions, the improvements in the care of older adults that they made were vastly different. Everything from Mount Sinai, Northwestern, St. Joseph's, and others, probably Mount Sinai in Toronto as well. I was referring to the one in New York, but that, you know, that really were uniquely excellent places for older adults, to one place that one of our colleagues went and visited where they had an unopened box of hearing aids. They couldn't remember why they were called the geriatric ED. And then one of the nurses was like, oh yeah, and then brought out this box of hearing aids, but the box wasn't even open. And so one of the reasons accreditation matters is because if you're going to call yourself a geriatric ED, I ought to know that if I'm bringing my mom there, and by the way, she's in Wisconsin at Advocate, and she goes to Advocate Aurora, and so I'm confident of the care she gets. But if I bring my mom there, something has been paid attention to the unique needs of older adults. Like, so public-facing geriatric ED ought to mean something. And then the other reason really is, you know, to empower all the folks on this line and across the world that want to do a better job for older adults. It's really hard to go to your money person. Usually don't go to the CEO, but like the department chair or the emergency services line chief or the vice president of blah, 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 the money person, the person that has to say no way more than yes, and say, I want to do better things for older adults. And like, these are some of the things I've thought of, and I need like another care manager. It gets very squishy and nebulous. It's very hard to advocate for that. So the other reason accreditation can be helpful, because it's the language hospitals speak. Everyone speaks accreditees. I mean, they just do. They get in line, they know how to behave, and you can hand them and say, you want to become a silver? Well, here's what it takes. Here's what it takes, Melissa or Joe or John or whoever it is. And then they can get their mind wrapped around that. They can say, well, these are the resources we need. Two quick stories on that, if you'll forgive me, Don. One story is when that really became clear to me is we were meeting with the VA leadership. Dr. Ragsdale's on, and she'll talk to me about the VA efforts in a second, but they are quickly becoming the largest integrated age-friendly healthcare system in the country, and geriatric EDs are leading their efforts in that front because of Luna and Eula and other folks' efforts on that. But we were meeting in the big VA building in Washington, D.C., in this impressive conference room, and we're talking about doing things better for older adults, and everyone's like, yeah, I love older adults, and that's great. But like, nothing was going to happen. You could feel nothing was going to happen. And then we brought up accreditation, and they grabbed the document that we'll go through in a second of the different levels, and they were like, okay, we could do that. We could do that. Hey, Sally, how could we do that thing over there? Could we do that thing? And all of a sudden it got concrete, and it got real. It went from, you should run that way for a while until you pass out from exhaustion, to run to that tree. There's a finish line over there, and you'll get recognized for that. Last quick story. One of the first site visits we ever did at one of the most prominent institutions in the Midwest, I was struck by the fact that, I mean, I'm just some dude showing up to do accreditation, but because it was accreditation, there was like 15 administrators in that room, and they were all in business suits, and they had their clipboards out, and I was like, oh, wow, I don't know how this just happened, but it moved geriatric EM from like this neat little thing to like, this is what we do. This is a certification we want. This is how we're going to perform. And that's the power we want to give the people on this line. Use accreditation to get what you already know you need. Use accreditation to get the resources you need to take better care of older adults.
Great. So Kevin, now that you are seen as a somebody in major hospitals in the Midwest, can you just quickly walk us through the 3 levels of accreditation, level 3, 2, and 1?
Absolutely. First thing to note is I am not a good counter. So level 1 is the highest. Think trauma centers, but so level 3 is the lowest. This has caused a great deal of confusion, but level 3 is the lowest, but it's important. So level 3 is bronze. Level 3 is meant to be in the zone of proximal development of every ED in the country. You can do it if you want to do it, is what that means. You need a champion nurse and a champion doctor who's really pushing stuff forward on the ground. You need to get they need to have some education. You need to get one good quality improvement project, or really good just improvement of care project focused, geriatric focused care initiative. And we can go into more details on that, but it's a way to get started. You need to make sure you have some basic equipment. Back in my hospital, mobility aids used to be like, oh no, you can't have a walker, you're an outpatient setting. I was like an outpatient setting, like I'm in the ER, like here I am. Hello, Joe. I think I'm at the hospital. But like, they're like, no, you can't. Anyways, you need to have access to mobility aids, and you can't tell people they can't eat after a certain time. And by the way, get food and drink for the daughter or caregiver as well while you're doing that. But anyways, you can do this if you choose to do it. You get started, you get recognized for it, you begin to till the soil for further advancement. Level 2.
Just before you go on, just so that people have a sense, because it keeps showing up, the idea of a geriatric focused care initiative. What does that mean? And give us an example.
Perfect. So it means you're going to improve your care processes with a focus on older adults in the emergency department in usually one of the 27 identified domains in the Geriatric ED accreditation guidelines. So for example, I'll give you a classic one, Don, you'll appreciate this one. Falls. It is not a geriatric focused care initiative to help people not fall in the ED. You're already doing that, both because you care and because of the 3,000 hours of meetings you're going to have if one of your patients falls in your ED. It's a geriatric focused care initiative to help patients that have fallen or at risk of falling, not fall after they leave the ED. Delirium screening and then intervening upon that would be another one. Identifying cognitive impairment and changing your discharge instructions and then your connections for care transitions would be another one. Elder abuse identification would be another one, and the list goes on. But we're going to do something extra good for older adults focused on their needs. And then you use that process and that team to maybe do more and more good things for older adults.
Thanks very much. So speaking of which, go on to the next slide.
Whole lot more to becoming a level 2 or a silver. Like, I mean, look, there's just more words on the screen. And one of the big things is geriatric focused nurse care case manager, 56 hours per week. Different hospitals fill that differently. They can fill that with nursing. They can fill that with care management or case management. And oftentimes the job of that person is not only older adults, but older adults have to be prioritized. So frequently they're leveraging already existing positions or advocating for new ones, more often leveraging already existing positions. But what that person is a quarterback. It's the person that, well, Don, you and I are doing the medical evaluation. We're looking for pneumonia, getting the urine, whatever we're doing. This geriatric focused nurse case manager is focused on what are the disposition options for this patient. We should be doing elder mistreatment screening for this patient. And so they pick a sub cohort of patients and really lean in and help that patient. That's where the magic happens lots of times. That's where we see decrease in admission of up to 16%. That's where we see significant cost savings. That's where we see some transformative care patterns. In addition, you've got 10 out of 27 policies. So now you are screening for delirium probably and falls and dementia, et cetera. You're picking 10 out of 27 and you're starting to track some outcomes. You probably have a dashboard at this point. If you've got a level 2, you've got a geriatric ED team that's meeting, say monthly, and they're looking at your dashboard like, hey, we did a good job screening for delirium, but we're not really getting physical therapy to come down to the ED. How do we fix that? So it's a strong, robust program where you're going to feel a difference. We have a level 2 geriatric ED and part of our UNC system. Our patients notice it. They definitely notice that it's a different kind of care.
And Kevin, we have one of the nation's best level 1s coming up to describe what they do. So in just a minute, review what the care would be like in general.
The gold standard. The gold standard. So I'm privileged now to get to begin to have conversations with CMS, CMMI, leaders in healthcare reimbursement, and I point to the level 1s and say, this is what a redesigned geriatric ED can do for you. The vast majority of times, it is not by like rebuilding your ED, unless someone dumps a van load of cash off in your driveway. That's tough to do. But it's by really paying it. You've got 20 out of 27 policies. You have PT, OT, social work, and pharmacy available. They don't always live in the ED, but they are a part of your ED team that you're calling down frequency. You've got the geriatric care manager. You've got a data dashboard. You are driving forward continuous quality improvement for older adults in your ED, combined with optimal educations for your nurses and physicians looking to treat EDs better and frankly, teach the rest of the world how to do it while you're doing it.
Good. Thanks very much for that overview. So as we launch into hearing from some of those places, Kevin, there's tons of really good and very pointed and specific questions coming up in the chat. So if you want to take a look and answer some of them, that would be great. So now I want to go to Green Bay, Wisconsin, a place that I barely knew existed, but I can't believe I've got through this far in my life without knowing that. I'm told that the level 3 geriatric ED there is one of the best in the nation. So we have Bridgette Dollhopf, who is the nurse manager of that site. And Bridgette, can you tell us how you got started on this? And tell us a little bit about what your geriatric ED looks like.
Yeah, thanks. So we actually are a 132 bed facility, so fairly smaller facility. We're a level 2 trauma center. 20 bed ED is what we have. And so we are in Midwest rural area. We had a case manager that we were lucky enough to have in the ED, a dedicated ED case manager. And she actually was kind of the one that got the ball rolling on our accreditation, because she had heard about the accreditation. She was working with a lot of those patients, and she reached out to Aaron, who you'll hear from in a little bit, who they kind of got connected because we have quite a few hospitals within our system, and we are all trying to implement accreditation across the entire system. So we started in basically the level 3. This has been great for us because we have 3 other hospitals in our small area. So with 4 EDs, this is kind of one of the things that can help to set us apart. We were already providing all the care that we needed for the geriatric level 3 accreditation. We really just kind of needed to identify those champions and kind of just tweak a few things, but we kind of called it like get credit for what we were already doing. Like Kevin kind of mentioned, it's really the basic. Level 3 is really the basic care. It really helped our entire nursing staff, physicians, really start to focus more on the actual geriatric population and kind of realize that, we do pediatric things, we do trauma things, but we didn't really have something specific for geriatric. And it's been a catalyst for other things getting going for us. We're incorporating other departments now into the ED that wasn't previously, as much. Right now, we are doing, we have one of the highest rates for our identifying seniors at risk. That's our screening tool that we use, which is in Epic, that we have our medical chart that we're using, and that we have one of the highest rates. It's just one of those things that's embedded in our team. They are screening anyone 65 and older, and they're making those comments in there for our case manager to follow up with. Even off hours, our case manager gets those screenings that are done, and she'll follow up with them the next day or on Monday. We are lucky enough to have that, so that is definitely a bonus, but it really is just kind of helping our frontline team that's working with these patients to kind of start thinking about the extra care that older population really does need.
So Bridgette, Kevin mentioned this idea of one process, that you need one geriatric focused initiative. What is your one process at your department?
So that's what we did, was the ISAR is what we call it. So it's that screening tool that identifies the seniors at risk. We already had the food option. I think we just had to tweak that a little bit. We already had the mobility aids down there. We identified our champions, but our team was already doing that screening prior to us even, applying for the accreditation. So that was really just something we kind of more hardwired and kind of pushed for that goal of 85%, which we've typically always hit or exceeded. So we are kind of looking at starting to implement those other protocols, processes for our level 2 journey at some point. And it's just, being able to kind of get, like I said, that ball rolling, that catalyst has really helped our team and some of our frontline nurses to kind of get more passionate about that geriatric population care.
Yeah. Thanks. I mean, I think it's a great example of how, I suspect there's a lot of folks calling in from emergency departments that they do some kind of screening like ISAR or other, but don't really think of that as making themselves a geriatric ED. But it gives you a way of structuring things that gets a ball rolling, and it can turn into a big ball as you steadily roll
Yeah.
on to level 2 accreditation.
Yeah, well, and like, I do think like it's just basic care, like Kevin has already kind of said, everybody's doing basic care. And really, why not get credit for it and set yourself apart from other, places and be able to say, we do focus on that care. So.
So good, thanks, Bridget. Chime in also further. I'm going to turn to your colleague, Aaron, who works more at the system level within your Advocate Aurora. So I think Green Bay isn't the only place that is doing this. How have you used accreditation throughout your whole system of, 20 hospitals or more?
Yeah, 26 in fact, and they keep on making more. So, but the process with this is accreditation, like Kevin's point earlier, was really a big impetus because we could translate this to our frontline workers, but now it's actually to talk to some of the leadership. It was a nice translation tool, if nothing else. And then actually with ACOs, and going from fee to service, fee for quality has also been a major part of that. In this accreditation, along with the age-friendly health system, these are major things that are in alignment.
So how does it change the conversation that you have? Like, what are the words that you use, and can you share those things with us?
Well, part of it is we can standardize. So if you have 26 hospitals and you have only one hospital doing one initiative, that's a drop in the bucket. When you have standardization, you have the whole system, you build it in Epic metrics, you can go up to senior leaders like, oh, we can assist you with X project, or this is a great platform for being able to connect closer to the primary care clinics, or vice versa. So it really scale, or standardization can get you to scale, and we use that through accreditation, and that really puts us on the map to be able to help the major initiatives of our system.
Leaders tend to like numbers. Do you have any numbers or statistics across your system that suggest accreditation or standardizing processes is helping?
Yes, and that's been one of our big things. Even is the process of metrics. One is in a dashboard, so we can say are we doing what we're saying we're doing. So this is process metrics. That's important as well. But now we really are building into the outcomes, and then what are those outcomes? So in the last couple of years, we've had a major push with this, and over the last year, we've also worked with our Aurora Research Institute, and we're actually, instead of saying there's a correlation, a 30% drop correlation between the ISR risk score and patients receiving service 2 orders post-ED, there's a 30% reduction in 30-day revisits. Now we actually have causation where we can control for all those different variables, and now that is becoming not only like a double gold seal that really demonstrates that outcome. So when we do work with our ACOs and other quality initiatives, there's a great background behind that. And that also helps us bring in additional resources. Bridgette was talking about physical therapy. We've done ROIs about having these different departments being able to work within here, and there is good outcomes as well as ROI for that.
Good, thanks, you two. I think it's quite inspiring, really, even for a place that may not be thinking of accreditation, just to know that tracking some of these things gives you some information and some resources to go to leadership as you want to make other changes in the geriatric emergency department. So feel free to chime in to answer some of the questions that are coming in too. I want to turn to Luna now. Luna in North Carolina at the VA Geriatric ED. Luna, you started, you're the representative for the level 2 sites, but your place started as a level 3 and then moved on up. Seems like a big move. Can you tell us a little bit about what was involved with the transition and what being a level 2 is like?
Sure. I think Kevin went through the differences in what's needed to go from a level 3 to a level 2. And I sort of look at that difference as, the difference between 3 and 2 is a bigger move, and it's a bigger commitment. And so like, let's say like level 3 is like dating or flirting with the idea. And then level 2 is you're in a heavy, deep, committed relationship with a geriatric emergency department. So we started as a level 3 because, I needed time to get our resources and processes and relationships built, but I recognized that the application fees were about to increase. And I thought, wow, I'll just go ahead and apply for level 3 because I know that's very achievable. And I wanted to sort of get my foot in the door, have a success, and then build on that momentum so I could continue doing what I needed to do to move towards level 2. And it was actually a very good system process for us because, my leadership was like, oh, wow, you're a level 3 accredited GERI ED, that's so great. And, and the question is like, what's next? And so then you can say, well, I'm going to go for level 2. And so what we needed to do was to sort of mobilize, look at what we had as far as resources and staffing. And, a lot of us are utilizing existing positions and not creating new positions when we're first starting out. So we had one nurse practitioner who was screening and providing case management for 20 hours a week. And as Kevin alluded to, the 56 hours a week of case management and or nursing championship is the biggest probably jump when you go from a level 3 to a level 2. And so that required a lot of thought and time to recruit other staff to be involved. We thought our program would be actually more successful in our workflow in the emergency department if we took it outside of the normal ED workflow. So instead of asking our nurses to provide these screens, we would have like a separate screener and care manager, like our nurse practitioner who wasn't providing care at the time. And then because of COVID, a lot of our staff were, ancillary staff were actually providing services not on site. And so that's, our social worker wasn't on site at the time, but we were able, because of COVID, to find additional workforce multipliers through a position that's unique to the VA, and those are intermediate care technicians. And intermediate care technicians are former medics and corpsmen, so they have this unique set of skills that they had training while they were in the military, and when they separate from the military, those skills are no longer recognized. Well, the VA is currently recognizing them as unlicensed professionals, but they're heavily utilized in many VAs. And so we patterned ourselves after our first level 1 GERI ED in Cleveland, and are using these positions as case managers and screeners.
And so how many hours a week do you have them, and what kinds of things do they do?
So they're providing most of the screens, and honestly right now, it's way more than 56. So there's some overlap in hours. So I think the original idea of 56 hours came from having 8 hours a day, 7 days a week. And that's just not feasible for us sometimes because of our staffing availability. And so we tend to go from like 7 to sometimes it depends on the day, but typically 7 a.m. in the morning to like 10 p.m. at night, about 5 days a week. And so I haven't done the math there, I'll have to think, but that should be more than enough.
I think it's enough. I would just, at our site, for example, I mean, we don't have anybody there on the weekends, but we do have 16 hours a day, 5 days a week. And as it happens, we get very significantly fewer old people on weekends. That's just the way things go. So, you know, matching your availability to your need is also important.
Yeah. And so they're currently providing for all our 75 and overs, and we target that population as we're starting out, because if we they're 14% of our patient population, and if we were to target all 65 and over, that would be like 44% of our patient population. So we wanted to have time to get more positions to screen, and we're getting there. But right now we're still doing 75 and over, and they screen all these patients when they come in with the instruments for seniors at identification of seniors at risk, and for delirium and for falls. And then there are further screens if their ISAR is.
So the other big difference between level 3 and level
positive.
2.
Follow-up phone calls.
I'm sorry, your line went dead for a moment there, and I interrupted you.
Oh, it's okay. They also are providing follow-up phone calls and coordinating sort of post-ED care.
So that kind of leads into, so the other big difference moving from 3 to 2 is the addition of a lot of policies and processes. So level 3 is just 1, you have 10. What are some of the other ones that you're particularly pleased with?
Because of COVID, we decided that it was, in the association with delirium and COVID presentations, we decided to screen everybody 75 and over with the delirium. And so instead of just identifying people who are at high risk, like with the ISAR, sorry, there's some background noise, but instead of identifying as like a subset, we decided to screen everybody 75 and over. And then in addition, we have a very strong relationship with our physical therapists and department, and they were requesting actually for more patients. So we expanded our screen of falls with a steady to all those who are 75 and over, and not only those who were identified through the ISAR.
Good, thanks. So just before we move out to the West Coast, I'm going to ask the same question I asked Bridgette. What do you think, what difference to the quality of care is this all making? What do you notice, and what do your patients say?
Well, I mean, I'll give a good example. And, you know, I keep discussing like the pandemic, because like this patient population has really been affected by the pandemic. And so there was this patient who came in their 80s with dementia, and the reason they came in was for high blood sugars and decreased PO intake. But through the screen, our intermediate care technicians had a deeper conversation with a daughter who shared that because of COVID, her in-home aid or in-home assistance had been affected and was disrupted. And now she is sort of on her own with her husband. And so we also had a caregiver burden screen, and she was identified as having caregiver burden. We included or asked the social work to help assist with providing some resources, which our social work was able to do that. The VA has a national caregiver assistance program. And so he was able to provide her with those resources as well as some local resources. And then our local VA site also has a program, a home-based dementia care program that aims at alleviating the caregiver's burden and hopefully delaying nursing home placements. And so we were able to put them in touch with this program. And I think, if not providing immediate needs, definitely helps the caregiver at least know that there are resources available and know that, help is on the way. And that's a huge relief, I think, to a lot of these families that are in, they come to the emergency room because because they're distressed. And, we in emergency are always putting people in touch with, consults and sort of navigating the system for them. And this is, I think, just an extension of what we already do, but to our more vulnerable population.
Good. Thanks a lot, Luna. That's very helpful in showing how accreditation or just good care makes a difference. So moving out to the West Coast to the age-friendly emergency department at the University of California, San Francisco, we have both the nurse champion and the physician champion, Mitchell and Nida. So Mitchell, can you describe your level 1? You started at the very top, so tell us what you do.
So just to give people context, we're an academic medical center in San Francisco with a city population of about 1 million, and 20% of our population in the city and county is over the age of 60. And 33% of our emergency department visits are for patients over 65. I think what we wanted to do was the emergency department wanted to be part of the broader health system effort around expending our attention on age-friendly care or age-friendly health systems to all clinical settings. And the ED had a specific interest in memory impairment and delirium. And so we are a consult service that's stationed in the emergency department 7 days a week, 12 to 8 p.m., which matches our older adult ED volumes over the course of the day. And then one really important thing we did was nurses, primary nurses in the emergency department are the frontline professional for doing initial assessments in the space of geriatrics. And so we gave them the ability to actually order the geriatric consult because they're the frontline professional completing the assessments. And it just takes the physicians and providers in the ED out of that conversation and eases the workflow.
Good. So how did you, what are, second question, I think at this level you have to have like 20 different processes. What are some of the extra things that you added that the other folks haven't talked about beyond ISAR and that sort of stuff?
So I guess the biggest one I'll add is, well, in terms of the assessments, the triage or the nurses in the ED do a total of 4 assessments. And then our age-friendly consultants do an additional 9. Of course, those are as appropriate. But the biggest thing is they complete a comprehensive assessment and plan that gets communicated, which I'll describe later. But the other thing was we created a quality improvement committee, which meets quarterly, and it invites community partners and agencies that and relevant internal referral services to review our workflows, our best practices, and integrate our work with those agencies' service platforms, and then meets the requirements of the internal referral systems. So for example, memory and aging clinic, which is in neurology, which is an outpatient service. The Institute on Aging is a big partner. And then we also engage with what's called the STEADY program, which is a comprehensive case management program that follows patients post-discharge for 3 weeks. We were also able to recruit a family member of a patient that I happen to care for in our service who joined our QI committee. And he's been an incredibly valuable patient advocate because he provides that other perspective on our processes and improvement efforts.
Yeah, I know that's one thing that I'd signal to our audience, that a big step up at the level one is the addition of some kind of patient advisory person or group. So that's not somebody who advises patients, it's a patient representative who advises the system and the clinicians on things they can be doing better. Can you think off the top of your head of any valuable learning points you've had from that person?
He did. His family was very challenged. Our emergency department and hospital did the best that they could, but he really described the value of partnership between our service and he and his family around how they were going to assist the mother in this particular case in terms of the transition back to home. And ultimately, she went to long-term care, but they found the work that we did incredibly helpful to help as a guide to kind of manage that care in the home setting.
Let me give you a specific example, actually. So we have actually multiple patient advocates on our advisory board, which is really great because you get a variety of different ideas. And so sometimes, as we know, the emergency department is a terrifying place, and it's more terrifying for older adults, especially those with cognitive impairment. So one of our patient advocates said, what would be great would be like what to expect when you come to an emergency department. Like, seems so simple, yet we haven't been doing that. And so one of the things that we're trying to work with her is putting together an actual booklet that we can hand a patient and their caregiver on what to expect when they come in, from the waiting room to what happens to them in the emergency department, and then what to expect at time of discharge.
So when you've got that complete, maybe you would share it with the Geriatric ED Collaborative, and maybe we would share it with the whole world, because it sounds like an extremely valuable resource. So back to you, Mitchell. What about, how does that kind of leads into how you interact with the community, and how do you get your community engaged with your ED, geriatric ED?
Well, I answered that just previously in terms of the community partners and agencies that are part of our quarterly QI committee.
And can you give an example of who some of those partners, those agencies would be?
Institute on Aging. We have.
Sorry, as a non-American, I didn't know that was a community agency. So, so I guess to me, making it relevant to every place. I think it's my experience that there are usually a lot of things going on in the community that the little island of the emergency department knows nothing about. And that's really one of the big gains in making geriatric ED or age-friendly changes, is that there's somebody whose job it is to find out, like, even how do I refer somebody to Meals on Wheels, or
the Alzheimer's Association, right? Like, all of those, there's so many organizations all trying to do amazing things for patients, but you just don't know how to access them. So having a dedicated social worker is really, really useful, but not every site is going to be able to have a dedicated age-friendly social worker. We're very, very lucky that we have that person to provide this type of extra resources. But even just talking to community partners, your Alzheimer's Association, your Association on Aging, the Institute of Aging that Mitch mentioned, and then your local Meals on Wheels. We have a program called Unlock. Talking to your local providers or nonprofits can actually give you a lot of information of what's locally available, right? Because you have these national organizations that do a lot, and they have some insight of what's going on locally because they have a local person. But then there's a lot of very local organizations that are helping your specific community.
Mm-hmm.
We also we meet bi-weekly with APS. They share 2 cases each 2 weeks that are challenging older adult patients in adult protective services. So it's a partner between Institute of Aging and then Adult Protective Services, and we review 2 cases each 2 weeks.
Great. So just as we're wrapping up, because there are some questions, but a lot of the questions relate to this one. How do you make this work financially?
So this is the kicker for us. So we needed a model that that could generate revenue. and address what health system executive sponsorship demanded in terms of knowing that our external funding that we have for our program is temporary. And so we shifted from a primary service delivery model, which would have been an ED-based nursing model, to a consulting advanced practice model that resides in the Division of Geriatrics. And so we had to demonstrate a sustainable workflow that would supplement health system demonstrated values such as improve patient caregiver satisfaction, reduction in recidivism, decreased length of stay, reduction in admissions when it was possible. So in setting up this secondary consult service, we needed to have an assigned destination for the revenue and a unique documentation template that tied to that destination. And so you'll get in the slide deck, there's examples of what that workflow looks like, what that documentation looks like, and also what the dashboard looks like. That will be part of the slide
So if I
deck.
understand correctly, then because you treat these people coming to the emergency department, the clinicians and staff, as though they were consultants, you're able to bill for their services. Whereas if they were an emergency department social worker, you wouldn't.
Correct. And so we use nurse practitioners and physician assistants as part of our age-friendly consultant team, in addition to a geriatric pharmacist and the geriatric social worker. And we come up with a comprehensive consulting note. So we're a secondary service to the emergency department.
Mm-hmm. I think Kevin may want to make an observation.
I've been so well behaved, Don. I know you're shocked that I haven't barged
Trying to
in
keep
yet.
a good man down.
But I just wanted, so that is awesome. What's happening at UCSF and a couple other places around the country where they're able, you can call in a consultant from another department, basically is how I think of it in doctorese. Like I know there's whatever, like if you ain't in the emergency department, you're a different department, then you can call in a consultant, just like I call cardiology or OB, and they can bill for their services. And what's really happening is a variation of a comprehensive geriatric assessment. What's actually happening. They use this as an opportunity to dig in there and find out how to help this patient. But just really quickly, I chatted this in too, since we have so many folks on the line, other reasons that this is sustainable from a healthcare system standpoint, in addition to possible consulting revenue, which will, though helpful, may not be entirely, may need more. One, there's kind of three buckets. One is sort of community image or market share. If you want to get real brass tacks about it, like pediatric EDs don't make money, but the fact that they care about your kids helps the hospital establish its footing in the market, and that matters. Geriatric EDs are similar. Two is getting the right patients admitted, especially right now. A lot of our hospitals are pretty darn full, or at least we don't have enough nurses to staff the beds we have, if you're going to get really blunt about it. And unscheduled Medicare admissions that do not need a big intervention like a surgery are not money makers, just to get very blunt about it. Like admitting the confused older adult with a UTI that may or may not be real is not a money maker for the hospital. And if they're not going to make money on that, and more importantly, it's going to hurt the patient oftentimes to bring that patient in for a long stay in the hospital. So being able to be more strategic about how they use their inpatient beds is sort of the second bucket. We call that case mix index, but it's like getting the patients in that really need to be in. And then finally, CMS has said by 2030, they want 100% of older adults, of Medicare beneficiaries in this country, to be tied to a value-based care initiative. You can't change the Titanic on a dime, and Aaron alluded to this earlier. And so the third bucket is, because of the work that you and others have done showing 16.5 up to 16.5% reduction in admission, up to $3,000 in cost savings over 60 days, the geriatric ED, or better managing complex patients like older adults in the ED, is a transition to value-based care. So just really quickly, if you got to pitch stuff, market share, optimizing your case mix index, and having a strategy for a changing reimbursement landscape that is value-based care. I'm done now.
Thanks very much for that coherent summary. If you want a review of it, I would just remind you that back in June last year, Kevin, Eula, and a few others did a webinar, which is available on the GEDC website, specifically on making the financial case. Laura, if you could go back into the slide deck, I would like to direct you to another resource. This is a recently published, last week published book called Creating a Geriatric Emergency Department, A Practical Guide. You'll notice that one of the authors is myself and the other is John Schumacher, another GEDC teaching faculty. We want to acknowledge the conflict of interest that we are selling this book and we do get a small amount of profit from it. I'm bringing it up because not only because it has my picture on the cover, so you'll definitely want to have it for that reason, but really we bill it as a practical guide. It will help you get started and provide you with tons of resources and personal stories about this. I noticed Jane Kermody already mentioned the chapter called Overcoming Resistance, What to Do About Yeah, But, and also making the case, but we really structure it around the 3 Ps of people, processes, and place. So what do you need to do to add training for your clinicians? What are the processes, the wide range of processes that you can add to a geriatric ED? What kind of changes to the physical environment do you need to make? Then subsequently, what kind of quality improvement? It is not an academic scholarly tome. It doesn't cost $300. It's a quick, practical guide. We've done a lot of the work for finding the tools and resources that you need and including them in the text of the book. It's available online as of today, so I would encourage you to get it. In our last few moments, I'm going to rely on the ever astute Dr. Yula Huang, who is the other principal investigator for the GEDC. Yula, any particularly important questions coming out of the chat?
So I would like, thanks again, Don. Thanks again to all of the panelists for a great session. I would say this is actually one of our higher attended sessions, and there were a lot of excellent questions directed in the chat. So if you haven't had a chance to, you're probably listening to the great dialogue and discussion, but also I think we've tried to address many of the questions in the chat. So please read the chat if you can, and we will be downloading all of these things onto the website. That'll include some of the links and the chat there. I just want to highlight, I think, some of the themes that were heard here. So you're hearing many of the hospitals describe, look at your own resources, look at a lot of your patient populations, and you're going to direct it. So you've heard some say, we have our GED initiatives focused on patients 70 and older. Others did the Medicare definition of geriatric 65 and older. They look to connect with many programs that are already there. So look in your own backyards, because you may realize there's a lot of programs that are already there that you just need to sort of now connect instead of having to start all over again. So just like really smart use and leveraging of things that are already there in your programs. I want to just highlight this audience is also full of experts. We had a great showing here today. Again, another international representation, many from the United States, but we had Canada, we had Switzerland, and we had also many different healthcare systems. So we had the VA. We heard Luna talk about the country's largest, US's largest integrated healthcare system. But we also have representation from Indian Health Services. We had several Kaiser hospitals on. We had New York City Health Hospital. So these are like the safety net hospitals for the New York City metropolitan region. And we even had a freestanding ED on the call. Leadership from many of these hospitals with nurses, nurse educators, social workers, chaplains, QI data analysts, PAs, MDs, patient navigators. Use your patients. We heard some really great examples and some really good questions in the chat about, well, how do you do what matters? Talk to your patients and ask them what matters. So, great session.
Thanks for that summary. Very wonderful, Yula. Next slide, please. I wish we had time to get to all of the questions, but just reminding you that all the chat and the chat questions and the chat answers will all be available on our website. Our next webinar is coming up in about 6 weeks, Monday, April 18th. We'll be focusing on delirium and cognitive impairment in the geriatric ED. So it'll be around screening tools and specifically how you can implement it and why you should. Next slide, please. Stay connected with us. Come to our website, follow us on Twitter, and next slide. Finally, I want to thank, as always, our supporters, the John A. Hartford Foundation and West Health Institute. And I need to do a big shout out also to the staff who so ably support us at the GEDC Nerve Center. That's Laura Stabler and Connor Sullivan. None of this would be possible without them. They make everything look easy and slick and well prepared, and it wouldn't be if it weren't for them. Thanks very much for being with us today. We'll look forward to having you back in about 6 weeks. Bye for now.